to go ahead and get started. As everyone settles in. Welcome. My name is Shari McIntosh. I'm the Vice President of Programs here at the New York State Health Foundation. I would like to welcome you to today's Conversation With event. We're really excited about today's topic, where we will be discussing various clinical innovations that are being driven by and co-developed with patients and their families. So here at the Foundation, we actually have a program area called Empowering Healthcare Consumers, and it's really our belief that patients should be placed at the center of the healthcare system. And we all talk about patient-centered care. But we also believe that we should think about patients as being members of the healthcare team on equal footing with other members of that team. And so in the same way that clinicians bring their own level of expertise to the table and to the clinical encounter, we believe that patients also bring their own level of expertise. I mean, they are the experts on their own health. They know better than anybody else what their illness journey has been, and they have preferences and needs for the kinds of care experience that they want to have. So what we're talking about really is this notion of patient as expert. And it's a really simple statement, but it's a bit of a radical idea because it does require a shift, or at least a rebalancing of the power dynamic between the patient and the provider. So easier said than done. So it's not about the patient being a bystander to their own health, or being on the sidelines or being a reactor. So, once you launch the new service program or the new clinical redesign, it's not about asking them after the fact, well, what do you think about this? So really it's about having the patient be a true partner at the very beginning to actually help develop and drive clinical innovation efforts. So that's what we're going to be talking about today, innovative ways in which the healthcare delivery system is being responsive to the idea of patient as expert, and really involving them in the care delivery and redesign process. So healthcare that is for patients and designed with patients. So I'm really thrilled to have our three panelists today here to discuss this topic. And I'll just briefly introduce them and then get us started. So I have Whitney here, Whitney Bowman Zatkin.
Close enough.
All right. So I think of Whitney as a disruptor. She is passionate and about connecting the dots of healthcare to provoke change for the greater good. She's the founder of Rare Dots Consulting, through which she serves as the managing director of Flip the Clinic, which is actually a project of the Robert Wood Johnson Foundation. And as you're going to hear from Whitney, and as the name implies, Flip the Clinic is really about turning the clinic experience on its end by really reimagining and transforming the experience where patients and providers actually work together to create pragmatic, usable interventions to improve the clinical care experience. So like I said, Whitney is a disruptor, and you'll come to know what I mean when you hear her presentation. And at the end, we also have Kathy Brieger, who is Chief of Patient Experience and Staff Development at Hudson River Healthcare. Hudson River Healthcare has 30 federally qualified healthcare sites and is a Planetree affiliate. And for those of you who aren't familiar with Planetree, they're an organization that's been around for over 30 years. And they do a bunch of things. They're all about promoting patient-centered care. They designate hospitals as Planetree certified. And they also have Planetree affiliates. And the Hudson River Healthcare is actually a Planetree affiliated organization. And in fact, they're the only FQHC in the country that is a Planetree affiliated organization. So at Hudson River Healthcare, Kathy is responsible for all programming, training, and evaluation of patient experience, and she'll be talking about how the Hudson River Healthcare actually walks the talk by really involving patients and their family members in all aspects of care and efforts to improve the patient experience. Last, but definitely not least, it was very important for us to also walk the talk by having a patient and family advocate here to talk about the importance of this notion as, patient as expert, patient being at the center of the healthcare system, which for all of us in this room, I know is really the true north of the work that we do. So we're really thrilled to have Beth Silver. Beth is a family consultant at the Sala Institute for Child and Family-Centered Care at Hudson Children's Hospital at NYU Langone Medical Center. She's going to be talking about her personal journey to becoming a family advisor and ways in which she and other family advisors have really helped to co-design and inform patient-centered care programming and activities at Hudson Children's Hospital. So just to give you a little bit about the setup for the day, each panelist is going to do a brief presentation. I'll have maybe a couple of questions for them at the end of their presentation, and then we'll open it up to the audience for Q&A. A few housekeeping items, women's bathroom at the reception areas you just walked in and also to the left. And we also have the men's restroom also outside to the left. A couple of other housekeeping items. The building is doing a safety drill today at 1 o'clock. So things are going to get kind of exciting at around 1 if they aren't already. So there'll be a brief alarm. You can ignore it. It's really for the staff. It's a safety drill, so don't worry about it. Stay put. And the other thing I want to mention is that we are streaming this event on Facebook Live. So welcome to our audience on Facebook. And you can also follow today's conversation live on Twitter. And in your handouts has the Twitter handle, hashtag NYS Health event. And just a shout out for an upcoming event next week on May 25th. In addition to empowering healthcare consumers, we also have another program area called Building Healthy Communities. And we're going to be doing an event about how do you design changes to the built environment to transform health outcomes. So we're going to be highlighting one of an organization that we awarded as an emerging innovator called Center for Active Design. So if you can make it back here next week, we'd be happy to see you. All right, and with that, I'm going to get started and turn it over to Whitney.
Great, thanks so much. Feels a little bit like an SNL skit. But anyway, let's give it a couple seconds. First, everybody, hi, good afternoon. My morning started a little bit ago, so if I accidentally start slurring my words, somebody come up and hit me really hard. I rode up from Washington, D.C. this morning, and we had a little bit of traffic issues, so I clicked it early. Come on, presentation mode. There you go. It's like I can nod at you as well. Oh, there you go. It's always something easy. Okay, so first of all, in order to demonstrate that people in Washington, D.C. do disclose things every once in a while, hi, I don't have any conflicts of interest with today's presentation. So first I wanted to just kind of have a quick gut check with everybody in the room. We've kind of all seen these data points at different reports or things that we're reading through, and I think it's a really great way to just kind of gut check where we are. The average patient spends about 8 to 12 minutes one-on-one with a clinician during an appointment. One of the very cool things the education community brought to our attention is that during an interval like that, only about 50% of the information is retained, especially if it's new. That number actually drops. And then the average physician is seeing about 2,300 to 2,500 patients a year. The recommended formula from AAFP, which is the Association for Family Physicians, recommends that formula is about 1,000 to 1,800 patients in order to be equitable and quality safe. So, looking at all of that data, that's where my good friend Thomas Getz launched into a conversation with some folks about what could change in the healthcare ecosystem. Sal Khan, as luck would have it, came to Robert Wood Johnson Foundation and gave a presentation much like this one over lunch and described some of the core pieces of Flip the Classroom. And it really ignited some discussion about what could possibly happen with those lessons and the root function of Flip the Classroom inside of a clinic. Flip the Clinic breeds on this idea of open experimentation and this idea that you could reimagine the patient-clinician encounter. As I get going, I'm going to warn you guys, whatever your assumptions are when you walked in this room, they're probably wrong. It'll be okay. I'll hug you afterwards. We'll get through it. All right, so what is a flipped clinic? So at the core of Flip the Clinic, we really truly believe in this idea that you have to learn by doing. We believe that everybody has something that they know isn't right and something that they probably have an idea that they could fix. By experimenting with it, which oddly enough is a really big hurdle for our healthcare friends to get over, but by truly giving one another permission to experiment, that's when we can find what is working. So we just wrapped up about 18 months where we went all across the U.S. and we worked in 8 different cities, and we gathered headaches from everybody in healthcare and things that weren't working, and we gathered a bunch of really great ideas, and we noticed that they kept clustering and having these sort of common themes. Through those, we actually created the elements of the flipped clinic. Right now, those are our best assumptions for what a flipped clinic looks like. However, I will warn you, they're evolving as I'm talking to you right now. So the first one is people-centered. I don't think that will shock anybody. We believe that regardless of how much you went to school or all of the other things that you might bring walking into the door, you are a person and we should listen to you. Expansive. This one's really unique. It grew out of a hospital that we worked with down in North Carolina, and I was lucky enough to work with early in my career. It's the idea that the hospital recognizes its place in the broader community and the impact that it has in the role that it plays. Joyful. We believe in break dancing physicians and hula hooping patients. Healthcare can be really tough and really difficult, but when you're focusing on having fun together or at least restoring something together, that role of caring takes on a different meaning. Nourishing. This is an idea that everybody has what they need to do their job effectively. Sometimes that is physical space. Sometimes that's Wi-Fi access that isn't doing something goofy. Sometimes that's just a supply room that's stocked and not 3 floors upstairs. It can take on lots of different meaning, but our goal is to create a work environment for the staff and a waiting environment and a care environment for the patient that is in some way fulfilling their best function for what they're trying to do. And then we've got transparent. So this one takes on a really interesting role inside the data community, but this is the idea that the power is equal in a medical setting. Nobody is top of the food chain and, somebody over here is not. Everybody's kind of got a level playing ground, and it also means that there's no secret curtain where there's like Wizard of Oz guy sitting with a light bulb and a microphone. So, what the heck is a flip? A flip is a bold new way of looking at the patient-clinician encounter. I always tell folks it's a really practical, pragmatic fix. We're not coming in and pitching you on a $4 bazillion medical ecosystem technology solution with iPads and wizards and God knows what else. We really look at things to be very digestible, very tiny cost. I like to tell folks when we're working with them, if it ends up costing about $20 per intervention, we probably screwed up somewhere, so we need to go back and do it again. So I'm going to run you guys through a couple of examples that I pulled for today that I thought kind of related to some of the stuff that we're doing. This Flip 55 is our digital record engagement flip. It's focused on getting folks aware that they can even ask for their medical records when they walk into a medical environment, and also informing medical staff that they are legally obligated to provide the medical records to people when they ask for their medical records in the format that they requested. We worked with HIPAA. We worked with a coalition, actually a couple of coalitions in Washington, D.C. to really craft this language and create tools that are helpful to everybody that's involved. Falling into this came, and I mention it only because I know it is an impact point here in New York, but bringing attention to things like being charged a monthly fee to access your own patient record portal. All of that falls into this. We're highly connected on the back end to make sure that we share the case studies and examples forward to HHS and others, and we've been able to make some great changes. This one is a lot of fun. There's a very fun comic group called Gaping Void. They do, if you guys remember those crazy motivational posters of like the skydivers, and then it said teamwork and like everybody should jump out of the sky together. So Gaping Void actually created this illustration with their lead artist, Hugh McLeod. And it says, healthcare begins here, and it has a little arrow over to the heart. They actually donated about 1,000, it's like 1,050 of those artwork pieces to Flip the Clinic to connect to medical practices, to clinics, to patients, to community health centers, to government offices, to small local businesses, whoever it is that feels like they have a connection. And it's been a ton of fun. This is us at Kaiser Permanente. We were there with these are actually a community group of architects and designers. And one of the cool things about Gaping Void is they've actually demonstrated that by just hanging a piece of their artwork in a common area, they've had a 5-point increase in HEDIS measures around quality. And then I wanted to talk a bit quickly about the role of the patient. So we have this flip, and it's focused on waiting rooms. And I grabbed this from this awesome report called Clinic 20XX by Cadre Research out in Texas. The main point of this is to show you guys that even though the wait isn't actually the longest in the waiting room before your appointment with a physician, that's the place where the most frustration is felt. So, observing that, what the heck do you do? Well, in the earliest iteration of Flip the Clinic, a group of folks got together. They identified that the waiting room was a frustration, and they sat down and they took a very academic approach. They met with folks who design waiting rooms. They met with folks who are experts on space use. They met with folks who have a wealth of information about other things that could fill the time. They created a beautiful flip, but guess what was missing? Talking to the patient. So they made a really great tool out of how to reconstruct your waiting room space. And then the patients came along and they said, well, what's up in the waiting room? Why is nobody asking me if I even like these light bulbs? And this awesome project started by Amanda, LA Lupus Lady. She launched hashtag Flip the Waiting Room. Sometimes it's hashtag Flip the Wait. But it's all about capturing the things that you love about a waiting room and sharing them out on social media. We've been compiling all of those, and it's created a really fun back and forth. But you'll notice it's about creating a soothing place. They don't mind waiting. They actually like the calm and the quiet. It's a lot more about, reconnecting and creating a welcome. One of the cool things that came out of this, the Livestrong Foundation has a medical center on the front of their building in Austin, for those of you that have been able to go. Their staff actually sat in their waiting room for 15 minutes. And so we started a 15-minute challenge, wait your own wait. And clinicians all over started sitting in their waiting rooms. The staff at Livestrong Foundation actually donated 2 separate Saturdays to go in and do little tiny things to improve the waiting room experience. The IT team hacked into the Wi-Fi and made a separate portal so that it would be secured for patients that are in the waiting room. Another team came in with magic erasers, and they got a bunch of scrubby marks off the walls. These are very tiny little things, but it completely changed their opinion of what that 15 minutes felt like. So what's next? I just want to briefly pitch to you guys. I'm super nervous. I actually chased our artist around this weekend to make sure I could bring this. We are about 60 days away from launching our Flip the Clinic playbook. It's really a hero's journey guide to Flip the Clinic and what that feels like. More importantly, I would offer that it's about the person going on the journey, not the system going on the journey. And I think it'll be a really powerful tool for people going forward. So lastly, I'll close with, what do you wish for at your clinic? Whatever you're walking through, if you're the clinician that's in that space or you're the patient, take a minute and think through that last horrendous exchange that you had. I'm sure we've all got something. Take 30 seconds, jot it down, shoot it to me in a tweet, whatever works for you. But we'll get some folks working on it. It's time to flip the clinic. Thank you.
Thank you, Whitney. So I have a question for you. So you were talking about the different core elements of a flip, and you mentioned transparency.
Yep.
And we at the foundation are very interested in that whole notion of making information transparent to the patient, to the consumer, to their families. So you talked about increasing access to people's personal health information, them knowing that they have a right to access that information. So could you talk a little bit about, I think that's been a big trend, like open data access is a big trend in patient engagement. Can you talk about other trends in patient engagement that are really connecting to some of the flips that you're developing?
Yeah, so it's not really a trend line with Flip the Clinic. So we don't treat patient engagement as this separate meeting that takes place or this separate action that takes place. We really believe that that's how you flip your clinic. So rather than, kind of checking a box and saying, okay, and we had the patient meeting, and we're doing flips that are patient-centered, all of ours, we really strive to make sure that they are. When it comes to data transparency, of course, there's been some increase in energy. The Federal Office of HHS changed a lot of their guidelines inside of OCR, or the Office of Civil Rights, around what is and isn't appropriate. And so you're hearing a lot more energy from folks. They have a public requirement, and part of what came to the table for the creation of this flip was a couple of us having coffee. And there's a federal report that goes out, and not wanting to point fingers, there was an issue where some hospitals were reporting 0 or 1 patient ever requested their medical records. I think we can agree that there's a mathematical error in that, right? So here's where the complication is. If you say 2, you then have to prove that 50% of those patients received their records within a specific guideline. That's another form. They're already doing a report with lots and lots of forms. So they were saying 1 in order to nod to the fact that they were doing it, and then moving on. And so we started to capture those case studies, and I think that's why there's been a spike, but I think it's been awesome how many patients are coming forward and saying, hey, heck no, this has been a hot mess. Yep. So yeah, and the more that we can do that, the better.
Yep, great. We definitely support that. Thank you, Whitney. So we're going to move on to Kathy, who's going to talk about the work that they're doing at Hudson River Healthcare Center.
Sounds great. Well, hello, everybody. I'm hoping I can see without my glasses, but just a little description of where I work. HRH Care, or Hudson River Healthcare, is a network of 30 health centers located in 10 counties of New York State. We've been around for 42 years. I've worked there for about 30, doing a lot of varying jobs. Right now, I'm the Chief of Patient Experience and Staff Development, and a few other things. Our health center is also, it's a federally qualified health center, which means that we, by law, must have a board of directors which comprises at least 51% of patients or users. So when we look at this, patients are our bosses. I can have somebody from the board meeting. In fact, I just had somebody last week talk about an issue that they had with some of the reception staff in a certain location. They're hands-on, they know exactly what's happening, and so they're able to ask, what's actually going on. We've been a Planetree affiliate since 1996, and what that means is that we've got a lot, we learned a lot from Planetree in that when you think about it, everybody's talking about patient-centered medical home now, patient-centered medical home, making sure you do all the clicks. And when I think about our first experience with Planetree, it was about really looking at that patient experience and how could we tie it into what we were doing. We're a level 3 NCQA recognized medical home in all of our sites. 2 of the newest sites in Suffolk County are being brought on as we speak. We'll talk a little bit about also my role in Planetree. I've actually coordinated that effort for over 20 years, and we've actually woven in this idea of patient-centered care in every aspect of our work: operations, safety, patient education, outreach. It's really been part of our fabric, as I would say. So we, like many other folks, get patient surveys. We've been doing this for 20 years. We may have started with the old AmbuQual surveys where patients were given a little card and had to fill out how they were. Patients that were unhappy did not receive those cards. And those things, the old days, how things were done. And then we're using Crossroads, which is a group that works pretty much exclusively with federally qualified health centers using telephone-based interventions. We get about 2,500 responses every quarter, and so this really gives us a lot of good information about how we're doing. We also do focus groups, and we do a variety of focus groups. One of I'll give you 4 examples. One of the examples is we had a community that was changing in racial and ethnic makeup, and we wanted to see were we really addressing the needs of this group because of the changing environment. And so we gathered a group and actually had this focus group and learned about what they felt the needs were. We also had we have regular conversations that ask, what do you like about the health center? What do you think we could do better? What don't you like? What do you like? And what could we do better? And then it's pretty much a free-flowing conversation. We've also had some work around trauma-based care and what were the needs for a special community, LBGT community. So we are able to actually design those special focus groups, which really yield a lot of great information. We also use patients in rounding. And you might hear this expression for those of you who are working in hospitals. Patients accompanying you on rounds is really very useful. We've had patients come in. We had some issues around appearance of some of our health centers. So we thought, let's not assume that we know what people are looking at. So we actually had patients at each of the identified sites walk with me and tell me, what do you see? What are you looking at? What's not good? What do you think we should change? Some of the things are really surprising. One of the things that was pointed out, our health center, because we're level 3 medical home, we're Joint Commission accredited, we've got a lot of recognitions, we have a lot of posters and information out there. We specially designed beautiful posters on hypertension, on asthma, and we plaster them all over the health center. Well, what was one thing that all the patients said? There's too many posters on the wall, get rid of them. So, and I'm the culprit of one of them, and I thought, wow, this is interesting, but you don't get that information. Another way we use patients, and this was an early lesson for me, I was in charge of a farm worker project to develop a prenatal flip chart that would be used in migrant camps. It was supposed to be just for New York State, and it ended up being it was a funded New York State Health Department project that ended up being used all over the country with farm workers. But one of the things that made the tool so useful, and that it's still used today, is that we used farm worker women to sit and tell us what they liked about the flip chart and what they didn't like. And again, some very surprising comments on how women's bodies and anatomy was illustrated helped to make changes that would really reflect the needs of those women. The other way we use patients is in cycle time. So for those of you who are familiar with this, there are IHI forms that people use where a staff member walks a patient through the whole experience of a visit, and they record what time they came in, what happened during that. Well, they're supposed to record what happened, what was going on to maybe cause delays, and then that information is reviewed by staff. Well, we've been doing that for a long time with staff members, but guess what? The patient-run cycle time yields the rich information that you need. You discover things that you might not discover if the staff members are doing this. The surprising thing with all of these, what I call using patients and quality agents, is that they love this because you're telling them, you need to help us. This is your place. This is your health center. We need your help to tell us where we're going right and what we're doing wrong. They love this because they really are the quality agents of HRH care. We also have, and I'm trying to put my glasses on, one very important aspect of this is that we do something called Planetree training every month. Staff members who've been with us for 3 months go through this training. It's a 2-day training. Early on, our CEO, Ann Nolan, said everyone must go. Doctors, nurses, frontline staff, facility workers, everyone who works at HRH Care must attend this. It's a pretty expensive deal. If you can imagine taking a provider out, full teams of about 20 people every month to attend this 2-day training. But it really does transform people, and it reminds them about why they went into medicine, reminds them about really what is important with patients. The thing that is, I think, most moving is that they actually get to hear from a patient. One of the patients that we have, actually it's 2 patients every month, will present a workshop. And that workshop is entitled Patient Experience. We ask the patients to describe the good, the bad, the ugly, and describe what makes a difference to you. What is important to you? And even though our providers and nurses see patients every single day, this is a different environment where people really talk about how this impacts their life. Our board of directors, also who are made up of patients, have helped us and do many things. They've helped us to do sometimes punk calls, which I'll talk about a little bit later, and they've helped us to do a lot of things. The last thing, organizational program, we report quarterly to the board of directors on the patient scores. We report at the quality committee. They want to know about incidents, but also about what are the things that are going on around patient-centered care. Executive council. I'm on the executive council, which also represents, it's the highest body in our organization. So hearing patient experience is really at the top of the agenda for HRH Care. We report also all results from our patient, those 2,500 patient responses go to every single one of our employees. So if you're a front desk person in Armenia, you get to see what the provider scores are in Suffolk County. So it's really transparent. We don't give individual provider scores, but we give organizational. And I want to say that what we're seeing, and probably a lot of you are seeing, this, when we look at the triple aim and the changes in some of the value-based payment, looking at this, finally we see an alignment with how patients are experiencing care. Our organization also serves as a technical advisor for the state health department doing this advanced primary care model. And one of the things that we're seeing is that an interest in making sure that we obtain patient experience, that we know what's happening, becomes central. And it moves beyond, for those of you who were familiar with NCQA's, it was in the 2014 standards, it was in Standard 1 and Standard 6. It was about engaging patients in the quality work that you do. APC and some of the other newer models are looking at moving people in a way that really integrates patient experience. It's not just about getting the patient evaluation. It's about how do you integrate patients into transforming healthcare? How do they become those quality agents that are going to make a difference in the healthcare that they themselves are experiencing? And lastly, I just want to say, with this, we're doing this intensive training, and we weave Planetree and patient experience in everyone's job training. But I was talking earlier about one of the slides that we use is that a nurse, a clinical assistant, is walking with a patient. And we say, this is the message we want everyone to get. We're not doing things to patients. We're not doing things, in any other way. We're walking with people. So whether you're a farm worker or someone who's homeless or a middle-class mom who might be single, whatever it is, there could be any variety of patient. We walk with you. We want to know how we can help your journey. And that's really what is at the core of what we're doing.
We did talk earlier about that. That was a powerful image. Thank you, Kathy. So a question I had for you was about being a Planetree affiliated organization. I was surprised that there's only one FQHC that has that designation or that affiliation, because when I think about health centers, when I think about FQHCs, I think built into who they are is being patient-centered. We talked earlier about it's like part of the DNA. So can you talk a little bit about how we can help to have FQHCs see like a Planetree affiliation as a national platform for them to share the innovation that they're doing, like you guys are doing there, and to also learn from others, but really to use that as a platform.
So I think, when we first became involved with Planetree, my CEO, Ian Nolan, had gone to a conference, and Planetree was doing a presentation, and traditionally it's been really working with a lot of hospital-based. I'm sure some of you out here might be a Planetree affiliate. And really the ambulatory care centers, FQHCs, were not really part of that. But when my CEO went to this presentation, she said, wait a minute, community health centers really are, if you think about this, they really are uniquely qualified to be part of the Planetree experience, because we are all made up. We have the board of directors that are patient-driven. We've always been involved with grassroots and grassroots work, community involvement, patient engagement. It's always been that way. But people may be thinking of Planetree as a hospital-based organization. Now, there's been some movement. I know Sue Frampton, Dr. Frampton, who's now she's the CEO of Planetree, has actually talked and had me kind of talk a little bit more to other health centers and folks about what it means to be a health center, Planetree. affiliate. And I think hopefully that will make some difference. I do believe that people should look at that as a way of really learning some of the things. We learned a lot about patient stories and the value of how we can use patient stories. We learned about the value of the training. We did a lot of those things to try to move, and I think other people can benefit from that.
Thank you, Kathy. So we'll hear more, but I wanted to pass it along to Beth.
Great. Hi, everyone. It's a pleasure to be here. I'm Beth Silver. I'm the family consultant for Sala Institute of the Hassenfeld Children's Hospital at NYU Langone. I recognize it's a long name. I lead programs to support partnerships between families and healthcare professionals. I come to you actually with a background in healthcare and from pharma and strategic planning, but all that really changed when my son was 2 years old and was diagnosed with leukemia. With a 3-month at home at the time, it became very hectic and lots of roller coaster feelings and clinician meetings, and it was a very long journey that we experienced in and out of the hospital, inpatient, outpatient, and even once my son was on maintenance, lots of additional hospitalizations as well. And so really after that long journey, I took a little time to sort of sit back and think about what I thought and what I observed while I was there experiencing a lot of that. My son is now 15 years old, and he's doing well. So I know, thanks. That's always something that we encourage many of our family advisors to make sure that we let families know how the family's doing, because we find that the audience is always wondering, how is the child? And, really can't focus on anything else that we're saying. So we can just cover that. So while I was observing and really sitting in inpatient and outpatient, I really had a lot of time to witness what was going on, really try and see, besides in my own inner world of thinking about my family. It was amazing to me to see that when your child is sick, it's not only the patient that's affected, that it really is the whole family themselves. And that as you look in the clinic or throughout the hospital in the waiting rooms, you can just look from seat to seat to seat, and you can see everyone's drama and challenges that they're facing. But the amazing thing is that they're all unique challenges. So very often in healthcare in the past, many of these challenges have sort of been generalized. Oh, when you have a cancer family, when you have a family with GI issues, you're all experiencing the same challenges, but that's really not the case. Many families are coming from diverse backgrounds, have diverse challenges, and really require additional resources really to really make them strive and succeed in caring for their child and the success of their family. Another thing I noticed is really how little things mattered, and I noticed that both of you actually mentioned that in your talk, and I thought this is positive. And really little things really did matter. When you walked into the clinic and someone actually knew your name and didn't call you mom, that was a big deal. Or if you were waiting for test results and it was delayed, and you began to wonder, were those test results not positive and someone's not coming by because they don't really want to tell me what's happening, or was it the fact that the test was just delayed? And so what I really appreciated was when a clinician came by and said, I know you're waiting for these results and the lab is backed up. And so this is not anything that has to do with your son's particular lab test. It just has to do with the lab. And then you can just sort of take a breath and realize, okay, we can recalibrate for another hour, and then we can worry then. But at least for now, we've got that hour of refuge. So that was a really powerful message to me. And then the last thing, and both of you again, we didn't plan this. So is that really that the communication and the treatment environment make a real difference. Really, when you're getting materials, you're getting information that's clear and concise, and that you can actually understand it. And it's true, I believe, when you're meeting with the clinical team, you take in very little information, and afterwards, and you have this meeting, you then can soak it up and really look at the references that you were handed. But if some of those materials aren't clear, and then you go back at home and you're looking at them and they don't make sense to you and they're really too complicated, you find that perhaps there's no one really to talk to about it. So those things really make a difference. And also the treatment environment. Are there chargers, or are there places, or is there entertainment for your kid? Many families have to bring siblings. And it really makes a difference how comfortable you are, and it really helps to the positive nature of healing by the clinics, the way they feel. If there's a calm, if there's a very hectic environment, that really does impact the way where your care is delivered. So really, after my son was treated, I really wanted to give back and start to get more involved in the field. And I had the opportunity to join Mount Sinai's advisory council. And so that was my first experience. And then I was fortunate enough to be hired by NYU to start their first family advisory council and begin this family consultant role. I was the first family that was hired at NYU. And so with that, I think came some real pressure to make sure that I respected families and made sure that I think people were nervous when I was in a conference room for the first time and participating in meetings. What would the family say? And so I think that it's been a really long journey, and one that's been very, very supportive at Hassenfeld Children's Hospital to respect families, and really had with senior leadership. I think that really makes a difference. We have a family advisory council that has about 20 different families, all really of diverse backgrounds socioeconomically, and also representing the diagnoses that we treat at NYU Hospital. And our goal is, and while I'm a parent, as I was saying earlier, we really try, our aim is to respect and really use the diverse background of our family advisory council, and really all of our family advisors, to make sure that we have an impact in the culture and care environment at the hospital, and recognizing that not being an N of one makes a difference, but really getting multiple and different perspectives really makes a difference in the care environment. And so many of the projects we've undertaken really have had that goal in mind. And I'll just give you a few examples, and I know we'll be talking on the panel. One was at specifically our oncology clinic, where the medical administration had asked us, can you look into seeing how the families really think about our clinic? But what we try to do at the Sala Institute at Hassenfeld Children's Hospital is really look at both not only the families, but the frontline staff and the clinicians, because we find by really partnering both the families and staff, it really goes a long way. In fact, at our Family Advisory Council, we do have staff on there as well as family advisors to make sure that we have a real accurate perspective and solutions to make sure that they're feasibly and can really make sure that they actually become productive. So at this project that we were asked to do, we interviewed families and clinicians and frontline staff, and we interviewed I interviewed all the staff and all the families. And what we found, there were definitely some emerging themes, that our families felt that they were very well respected, their dignity, they felt well listened to, they felt that they were not in a rush, and we felt that, and then by interviewing the staff, we learned really the other perspective is that the staff wanted to do more for the families, and they felt that there could be more of a coordinated level of care. And the little inklings that the families would say started to make sense in sort of building out that full picture. And so when we met with the clinical team at the oncology clinic, we really discovered how can we perhaps include and improve the coordinated care. What can they do? We know that families travel long periods of time to get to the clinic, and sometimes they are late. They come in frazzled, they come in hectic, and now they have a whole day of chemo. So how can the staff really be attuned to them and let them know, it's okay that you're late. We know that you're here. And so how can we sort of let everyone know that we're on the same page? We learned from families that they wanted different kinds of refreshments. And it's those little things that the staff said, oh, we know we have refreshments for them. And even the staff said, but we know it's not enough. And so their comments really did mirror each other, and that they really were identifying some of the very same issues. And so it's a project that we met, I guess it was around the winter time, and recently I had a clinic checkup with my son, and he said to me, Mom, it looks great in here. Things are moving very smoothly. And so I think, it's really nice when you actually see positive change, and that makes a huge, huge difference. Another project that we worked on, really one of the first projects that we worked on with our Family Advisory Council, and really most of the clinical staff that work alongside of us with the Sala Institute, was an environmental scale project. And we looked at not only, we really wanted to see what the healthcare environment was within NYU Hassenfeld Children's Hospital. And so we did a series of meetings where we were interviewing families in all different clinics, and also we interviewed our Family Advisory Council, and then we also interviewed the clinicians and the staff and talked to them about what their different attitudes were. And we, for our Family Advisory Council, when we were looking at some of the physical attributes, we all paired up where we had a family and a clinician walk around the different hospitals, and they were all assigned to different spots. And it was really amazing to hear what people said, very much like what you're both saying in terms of the environment. We found some posters, some signage weren't translated. Some things didn't feel safe, the way they had certain cushions piled up. Families felt that some places weren't private enough. And so those were what we really tried to identify as the low-hanging fruit. Those were things that we could do immediately, and we could set out to change those. The more complicated issues we found were issues that families and staff identified as sort of more deeper projects about bedside shift report, change of staff, some of the morning rounds, some of those more complicated issues. And those projects that were identified in that environmental healthcare project has really led most of the work and most of the projects that we've been working on for the last 3 years. And it's really set our priorities. And in fact, we are building a new children's hospital, and many of the key components that we've learned from that study really guides a lot of the work that we do today, and has guided almost all of the aspects within the design of the hospital. Families have been involved in everything of that hospital, with the digital component, the physical component. I've sat on so many chairs and beds and couches to make sure that they're comfortable, and making sure there's access to being able to charging stations, and so really involving families, and that's really progressed. And then just the last example of just some of the work that I've done is really looking at there's an integrative behavioral health project where we were working with our GI team initially, and they were looking at how to move on an outpatient basis some of the clinically centered behavioral health issues, and knowing that many families, when they have a health issue with their teen, it also leads to behavioral health issues as well. And so this was actually a research project and an improvement science project as well. And we had families involved from the very beginning. And what's amazing about it is that when the families started to look at some of, let's say, the recruitment and the designs of the projects, they had, I think when the team created some of the recruitment projects, they had a picture of a teenager. And one of my family advisors looked at it, whose son in this particular case has GI issues, and said, "She looks so depressed. I would never look at this piece of paper. I would never want to see what it has to say because it's terrifying," and I would just walk away. And so the team was so surprised because they thought it was really reaching out to what the families might want to be seeing. And so we all looked at different images and picked some that actually several members thought was much more favorable and inviting. And in fact, we had a poster, because we have a large Orthodox community, we had a poster where they had several people in yarmulkes, and so we have an Orthodox family on our council. And so I was showing him the poster, and I said, what do you think of this? And he said, not knowing, what type of behavioral health project this is, he said, is this something that's contagious? So I said, no. And I said, why? He said, because this is on a street in Jerusalem that this picture is taking place. It doesn't look like it has anything to do with what you're doing, and I think people might think it's a contagious thing. It just might have the wrong message. And so we changed it. And so it was just something that, by myself, looking at it, I would never have known this would have, that kind of impact. And so by changing those images, the study and the actual project is having such wide success that the clinic first started with GI, now it's moving into diabetes, and it's really expanding its focus because it's been successful. It's meeting families with where they are and trying to be more proactive and really more engaging in a positive way, meeting in families. And families were involved in the co-design and co-production of this entire behavioral health study. So it was really a fascinating experience. But I guess just as a summary of some of my experience experience as being a parent, that I often go to many of these meetings and I think, oh, by this time I've been at the hospital a few years now, I should really think like everybody else. And even just last week I was in a meeting and I thought, what? And so I think that it happens. Yeah, and it's an amazing thing. And so I wonder if parents weren't there, if families weren't there, we have support of leadership to have families included. If we weren't at the table, then really what would happen? And so by having families included, we're able to really make sure that the partnership continues. And it really is impressive to see how we've been able to change the culture. So thank you.
Thank you, Beth. I do want to ask about, you mentioned culture and how you sustain this, and then I'll open it up to the audience. So, I think if you were to ask any provider, is being patient-centered a good thing to do? They would say yes. Is it the right thing to do? They would say yes. Is there tangible value to it in terms of patient safety outcomes, health outcomes, obviously, cost savings, the list goes on and on. I think all providers would say yes. But the reality is that, it's still a bit of an uphill battle to kind of flip the culture and change the mindset. So I guess my question for you and then for all of you is, once you have the buy-in, once you have everybody saying this is the right thing to do, we should do it, there's value to doing it, how do you sustain that culture shift? You mentioned just last week, you're like, what? So how do you really sustain this work moving forward?
Well, two things that we've done that really I believe help sustain it. One is that we have family advisors really on every safety committee and quality committee, and I sit on safety and leadership quality committees. And so by having that constant family present, that it's something where it's not a check the box, that it really is integrated in the day-to-day routines, the real big strategy projects, the small projects that you're doing, and then the big macro projects where you have a family presence possible. In fact, we had a family advisor who was sitting on the ventilator associated with pneumonia committee, and she's a parent, and she was talking with the team, and they said something about how they clean the yank hour, and she said, which is a technical term that I'm not as familiar with, and she said, oh, I know exactly about how to clean that. And when she described what she does, they said, no, that's not correct. You're supposed to be cleaning it another way. And she said, it was all about transparency. How do you have families know the exact way? And so they ended up creating a diagram and really, moving to that next level of how to explain it to families. But by having that family there, it ensured that message was going to take place. And then in addition, we have a family faculty program where once a month I teach new nurses that are moving to pediatrics but also new to NYU. And I often share it with another family advisor who talks about their specific experience that they've had in the hospital, and we talk about what we appreciated and what we've learned from our experiences, and we really talk about family-centered care. And these are new nurses, and then some nurses that have been in the field for so long, and they often want to know, they have lots of questions about things that that seem almost to us really about communication and transparency, but sometimes with their hectic schedules at work, it's helpful to have a family talk about it. We teach new residents about how to talk with families. We've given talks to our to team meetings. Really, anytime we see the need for it or someone reaches out to us, we talk with them. We have a regular session with also medical students as well, as they are rotating in pediatrics. So we really try and expand our family faculty program, and we also we have people rate it so that we can always improve our process and make sure we're messaging.
Thank you. Did either of you want to add to that? And also, Kathy, I'd be curious your thoughts on not just sustaining this work from a health delivery setting kind of vantage point, but what can you do around policy? You mentioned the APC work that you're involved in doing. Can you talk a little bit about that as well?
Well, I think, as far as I'll talk about sustainability quickly, and I think that because it's been a lot of this Planetree aspects of our care and work has been really integrated into all aspects of our organization, it feels pretty strong, and I think that only continues. We've had to morph and change as things have happened. PCMH, we've actually had to do some things to protect patient-centered care around the PCMH, because sometimes it becomes all about the clicks and not about patients. Okay.
I told you it was going to get exciting. Around the class.
Action Plan Director. At this time, we are conducting a shelter-in-place drill. Please do not leave your floor at this time, as elevator use will be restricted for 5 minutes.
Who's got the plastic tape?
At this time, we are conducting a shelter-in-place drill. There is no use of the elevators at this time. Elevator use will continue in 5 minutes. I repeat, elevator use will continue in 5 minutes. Please shelter in place at this time.
So I think, in looking at the...
This is just a drill. I repeat, this is just a shelter in place drill.
And no elevator can be
All right,
used.
Kathy,
Okay.
as you were saying, Kathy.
So I think in the changing marketplace, we all know, we're all learning about, the shift now to value-based payment. How is this going to affect the patient experience? How is it going to affect how we do things? And I think it actually gives us and lends us some more support for moving or shifting to this model from an economic standpoint or a financial standpoint. We know that patient outcomes are impacted when they are more engaged and when we actually listen to what they're saying. When they're sharing in decision making, you're more likely to know that this patient is going to be able to follow a regimen that they helped design. And I think that if you look at CMS, if you look at some of the private payers, everyone wants better outcomes. It's a no-brainer. And if we look at this and say the changing policy landscape is really moving in this direction, we need to make sure that we're aware of how is it changing, whether it's APC or CPC Plus or any of the other models. We need to make sure that we're helping to inform. How do we measure patient experience? How do we include them as quality agents? And I think there are many opportunities there, whether you're a small practice, large hospital, place working with low income, place working with, middle.
May I have your attention, please? May I have your attention, please? This is your Emergency Action Plan Director. At this time, the drill is concluded and elevator use will continue.
Last 5 minutes.
I repeat, at this time,
A 3-minute, 5-minute.
included, elevator use can continue. We appreciate your cooperation and we apologize for any inconvenience. I repeat, we appreciate your cooperation. We apologize for any inconvenience.
All right.
Thanks, man.
So just in closing, when I think of, what are the resources out there? Maybe you don't have to become a Planetree affiliate, or you don't have to really create a lot of extra bodies, but I think that we all can take the steps, some simple steps to actually start getting information, but also to act on it, to actually integrate it into the daily operations of what you're doing. There's a great handout that just came out in April. I think it's about 11-page handout with the Planetree actually helped to write this with the Patient Safety Collaborative. It's a free resource. If you go to the Commonwealth website, you can actually download it, but it gives some concrete steps about how to do this. I would also suggest, like the APC model and other places, negotiating with your managed care companies if you're working with private insurers, that looking at patient experience, what are the things that they want you to look at? Often it's around access, because and also when you look at ER use and everything else, it's all tied in with how patients are engaged and how well they are being included in the shared decision making.
I'll just briefly say, and it may be a little jarring for folks to hear, but, at Flip the Clinic, we really try to focus on the human side of healthcare. So we really try to take a hard stop and look at the people that are functioning in this system, because that's where the change is going to happen. You can go in and you can build a set of stairs that have, a lower rise level, so there are more steps. So therefore, everybody going up that staircase will get more steps in their daily day. But it's still the human that has to come and do those steps. When we think about hospital-acquired infections, when we think about any limited English proficiency population, and some of these things that we've, more or less solved, much like the polio vaccine, we still have people that won't get it because of access issues or whatever it might be. And so when we look at things like culture shift at Flip the Clinic, we really function like this sort of rehab center to say, like, it's okay to love your job and be in healthcare. It's okay to want to be able to connect to your patients and care about them. It's okay to have your heart out there and be super committed to your job. And we really try to, restore the broken DNA in the fabric of these human beings and make sure that they have what they need to carry forward. And so, you won't hear me up here giving you a flashy PowerPoint slide with a bunch of data points about, quality measures and the time that we save 52 cents doing this thing on our left leg instead of our right leg, stuff like that. You're not going to get that from me, but what you will get from me is a rattling list of people that have come forward. And, I'm the whisper network. I'm the, we should be doing patient engagement. I don't know what it is, and I can't come out in public and say that because people will, stop coming to my hospital. I have 3 meetings about that next week in California. So these are very real things that are happening. Words are scary, healthcare is confusing, patients are lost, and everybody's trying to do it better. And when you throw on top of that a massive overhaul of the basic components in that system, people are exhausted. And so I think I would put forward that when it comes to this cultural shift, we've been uniting people on the kind of more fun, very serious, like, let's get rid of having, Betty have to run up and down the stairs every time she needs a XYZ folder because the only place that we could figure out to store XYZ folder is upstairs 3 flights away from her. That's a real thing. And that's not a real thing I heard one time. Think about that. Like, come on, guys. So those are the real things that we try to take on and shift. And I think those are the awesome moments that create the tentacles for permanent change, without having to create a whole new system or a whole new building in order to capture it.
Great, thank you. So we're going to open it up to the audience for your questions. Thought I saw a hand. Oh, yep.
I'm Catherine Craven from Mount Sinai. I'm a senior clinical informaticist. Sorry, I used to be an informationist. And that means I work with the electronic health record systems. And so we're particularly interested in reaching out through my, my chart, the patient portal, and other things. But that's not the question I want to ask. I'd actually love to pick all of your brains for the next 3 or 4 hours or maybe days. But my specific question is actually for you, Catherine. If you could tell us just a little bit more, if you can, about the patient-run workshops that were held. How are the topics selected? How are the patients selected? Where all did these run? Are they still running? And just a little bit more detail. I'd love to hear more about that.
Okay, so every month we have a group of about 20 employees that are going through this Planetree orientation, which is 2 full days. And one of those is focused on the patient experience. The title is Patient Experience. And we select randomly patients. So we have a core of about maybe 10 patients that come, and I prep them because I say to them, we want to hear everything. What has not been a good experience, from the front desk to the phone calls, everything. And I ask them I tell them they have about 20 minutes because this way they're able to express what has happened to them. We do give them a gift card because with their time in getting there. I think it's $25. Oh, no, wait. It's $50 because some of them have to travel to and from. We also have, when I ask them also, when they look at a healthcare facility, what are they looking at? Quality. How do they see quality? And it's funny because some of them have gotten more and more proficient and more excited about doing this. They've been filmed. We've actually filmed them, and we're doing some work with our board of directors so they could actually hear what the patients are saying. So that's pretty much, but it's Patient Experience is the title, and it's really asking them to do kind of this targeted talk.
And can you maybe give 1 or 2 examples of sort of aha or surprise moments that maybe affected some change, whether it was big or small, but made an impact?
Okay.
Or,
So this is interesting. There's one woman who's just about 70, and she's articulate. and just really just a great storyteller. But she talks about how when she first came to the health center, she was married, and her husband would drive her, and she had a great doctor that she liked, but her husband died. And when he died, what she didn't know is she had almost no money. She was going to be kicked out of her house. So here was a woman, not wealthy, maybe lower middle class, but all of a sudden she was on the verge of becoming homeless. She had to learn how to drive. She said when she came to her next appointment, all she could do was sob, the primary care provider. But she describes how he, in a very human way, comforted her and said, look, we're going to be here with you. You're not alone in this. And even now, just thinking about it, it makes me feel like I want to cry, because she talked about how then he got her help with a social worker. The social worker said, you're going to make it. You're going to get through this. The social worker helped. Even our ops manager, who, this place is pretty big. It's our peak skill site. They have over 15,000 patients. She knows that woman. Again, knowing her by name, said, don't worry, we're going to get you through this. So it became, a whole team effort. We're gonna help you with this. And so now, 3 years later, it was funny because her doctor is leaving for another site, and she said, I told him, now that you've gotten me through this and I'm feeling stronger now, I'd like to find a new husband. So maybe you have to help me with that one. Now, we're really not in that business, I'll have to say, but the idea that, it really spoke about this woman who came from a place of, I'm here for healthcare, but it's really much more than that. People come to you for so much. And then the other woman, who's a younger woman, actually, she is a mom of a 9-year-old boy, and she happened to bring him one day to one of the talks that she was giving. So I asked him, I said, tell me about something. Tell me, when Dr. Simpkins sees you, does she talk to you, or is she only talking to your mother? And he described this in his own 9-year-old way of how, that the doctor asked him the questions and that he was the one answering the questions. And I think hearing that, it became evident that patient engagement begins at the very youngest age. So I think that those things are so powerful, and I think those are just two examples of maybe aha moments, that you don't have to be a 40 or 50-year-old person to become an activated patient.
Thank you. We have a question here.
Hi, my name's Jim Guest. I used to be at Consumer Reports. I'm now on the advisory board of Open Notes, and was at a conference recently that had clinicians and patients and consumer advocates and so forth. And a couple of ideas emerged about humanizing the relationship and having transparency and kind of a sense of equal partners. 2 ideas came up, and I'm just wondering, we have no idea if they would work or not. It's kind of like you were saying, you try stuff and you see. I'm wondering if anybody's had experience with either of these. One was the whole notion of asking questions, trying to make it safe for patients who often are fearful about asking questions. Maybe take your posters down and put 5 questions up on the wall. It's okay to ask these things. It's safe. Go ahead and do it, or something like that. But any experience on encouraging the asking of questions? And the other one was the idea, again, of trying to, somebody said, these are people. These are individual persons. It's not the clinician with all the, the diplomas on the wall. It's one person talking to another person. And the idea may be that while people are sitting in the waiting room, you might just have a little 100-word kind of mini bio about the clinicians, but it's not their professional credentials. It's, I'm a family person, I have 3 teenage kids, I know what it's like trying to juggle stuff, I happen to like sports, I play tennis, I'm a New York Yankees fan, just something like that can kind of be an icebreaker when somebody comes in for the conversation, and maybe make it a little easier and safe. And any experience on either of those ideas?
Yeah, definitely. How comfortable, how nerdy may I go with you, Jim? Okay, good. Just want to make sure. So on the first one, we actually have a flip that was created. I'm not sure how familiar you guys are with motivational interviewing, but we have one of our very early flips was, it basically built a deck of playing cards to stimulate conversation. And what it did was teach patients the same type of question process that clinicians use in the exam room. So it's not completely the process of diagnostic decision making. However, being able to figure out where the patient is as far as income, comfort with prescription medications, all of these other things. The cards are very beautiful. We've had a couple patients here in New York get them off of our website. The full PDF file is there, and if you need the artwork files, I tell everybody we're happy to send them out, and you can co-brand them however you wish. But they're built in a way to give people a couple of little papers to look at and think differently about saying, well, I'm frustrated at work. Or, well, I'm really tired. Tired means a lot of things to a lot of different people. So, helping a patient kind of expand the vocabulary a tiny bit into different trigger words for clinical settings is a really beautiful and valuable tool from a lot of different angles. So anyway, check that flip out. I think it's number 4 or number 7. So yeah, and then with regards to your second part about individual people, comically, I tell people that one of my best experiences in healthcare was when the doctor opted to meet with me before I changed into my paper gown. It seems kind of ridiculous, but holy crap, did that set a different tone for the appointment, right? So yeah, but there is some really interesting research from Oliver Wyman Associates that just came out, and it was talking about how disparate populations make decisions about what clinician they're going to work with. And so how do you build that trust with somebody, and what does that look like? And one of the revealing things is regardless of income, all of the patients are going to a web device to look at the practice. However, just by the proxy of biasing you guys because you're in this room, I'm guessing you probably look for credential and experience and education and maybe their quality ratings. Maybe you go for a web-based review platform or something like that. Those of lower socioeconomic status or means, the number one thing that they reported back in this study is that they look at the profile to determine if that person is going to treat them fairly. And with respect. And so one of the big encouragements that we've had from Flip the Clinic in regards to that piece of data, really take stock of what your presence is on the internet. Take a headshot that shows who you are, not like that you know how to wear a white coat with some embroidery on it, because I think we can all pull that off. Many of us have for Halloween anyway. But figure out a way to be yourself in that moment. And I think those are the really beautiful things that you can start bringing into the medical practice and changing the perception of your patients and what they take away from you.
So, did you
Go ahead.
I have 2 thoughts on that. So we've done a project where we created something called the mirror image tool, and what we found is that really when patients and clinicians are understanding the other's perspective, that it really levels the playing field. And so we've created these documents, and I was involved in the first one that we did was for central line care, and really went through what the dressing looks like, why your child needs it, what to expect, and really went through the entire procedure and routine in very bite-sized comments. And although they weren't questions, it was really helping the family to understand sort of what the leveling of the playing field was, because on the other side of the document, we talk about what the clinicians are expected to do and what they might expect of you, and so that they understand what's coming next. So we've done that also with some of our family-centered care rounds and some of our other hospital-acquired condition committees. We put things together like that. And what we've noticed, and the one comment I have for you is just if we're working on questions for families or clinicians, knowing that every family is going to choose on one day to participate in some of these questions, and the other day they may not. And so really understanding that even not everyone's the same, but one person may react differently depending on what day's stressors they're feeling. And so I think the more transparent the knowledge is it a way of really creating more communication. And then as far as your talk about humanizing, I think, clinicians, we've had a lot of discussions about this in our design of our new hospital's digital wall. And so when the clinician will be coming into the room, because we figured out, I think 50 people can come into a hospital room for the day, really trying to have, and we've had long debates of our Family Advisory Council, what would you want printed? Do you want? I have 2 kids, and ironically, one would think that families always would want to know that, that they do have these credentials or that. And many of our families said they didn't want to know a lot of the personal stuff, because then they thought that the clinician, and it wasn't a uniform answer really, that many of them actually didn't want to have such anecdotal information about their clinicians, because they really wanted them to think of them in a more thoughtful way and know that they did have the background. And so so it really wasn't a unique perspective. It wasn't a unanimous perspective for everybody. So it was interesting to see how the group really varied in the way they thought about that.
So I just mentioned one thing. We use this Ask Me 3 program. Probably a lot of you are familiar with that. And I think it's a way of we've been working with our staff and our patients to become more active partners and engaged in their care, that they are encouraged to ask these 3 questions. And there are lots of materials, posters, and other things, because it's part of a national campaign for about 8 or 9, or maybe I don't know how many years, but it's been a great program, and we use that to encourage our patients and also educate our staff that these are the 3 questions. But it actually opens up the conversation for more. Then the other question you had about, I know with NCQA one of the requirements was that people are able to select their provider, and so what many places have done is to actually on their intranet actually created some very basic descriptions of their clinicians, but I think it depends on what places are, how they're doing that. I know we hired a photographer who captures people, kind of their quirky personalities, and that's been good. Anyway, so those are just 2 thoughts.
Yeah, I will just add an idea into the mix. So, Kathy, you mentioned Ask Me 3. There's also a program called, not really a program, but this idea called Tell Me More. And it's a set of 3 questions that are posted on a poster in a patient's room that says, what's the thing that's most meaningful to you? How would your friends and family describe you? What matters to you? So whatever the 3 questions are. And the point of it is to humanize that interaction. So whoever enters that patient's room, be it the food server, the clinician, the resident, whoever it is, it's a big, huge sign on the room that kind of forces you to engage with that patient in a holistic way, rather than this is, patient X with this disease. So lots of good ideas out there, from the most kind of complicated and complex to like the most simple. So I think there was a question right here.
Hi, my name is Kara Ferber. I'm currently volunteering as a policy and advocacy director for Pink Concussions, which is an organization that we did some lobbying in D.C., but also work attending different conferences to advocate and promote more medical research on concussion and brain injury, particularly for women. But previous to that, I was at NYU Langone for a long time, and did some work at the Concussion Center, and also while I was in graduate school for a master's in health policy and management, did some consulting work for a doctor there who was developing a brain injury advisory board, which I'm not even sure has happened because I know she ended up leaving the hospital. But I guess my question was about any guidance for both for children or for in the sphere of mental health, or for difference acquired or traumatic brain injury, any guidance for like healthcare decision making on the pathway to care. And I think a lot of what you spoke about was more modifications or changes in delivery of care. But I think now, especially with the changing policy landscape, a lot of patients don't know where to go, what to do, and it's an issue. And so I was wondering if there's any initiatives, at any of these, health medical centers or organizations in this area.
I'm happy. Yeah, I can. So the last 8 months, Flip the Clinic has been doing a deep dive with a practice in Allentown, Pennsylvania. So if you can, I strongly encourage road tripping out there, and I'm happy to meet you up in Allentown. It's a really dynamic pediatric behavioral health practice. It's extremely collaborative in a couple different ways. And I guess the example that I'll relay to you in the couple of seconds that we have, and I'm happy to chat with you afterwards, they capture something like 15 data points, including full genotypic and phenotypic data. They then sit down with the patient who is under the age of 18 dealing with some sort of developmental issue or hurdle, and are able to describe how they are built using genetic data in real-time conversations with these children, explain to them what their superpower is, and then help them understand that what's happening is, they're going to make a plan to heal and pursue the best of what that child's life could and will be. And I think it's a really beautiful example of everything that you're talking about. There are pieces in healthcare where things have to happen differently. But this practice, Children's Integrated Center for Success, I strongly recommend that you follow them. It's not the world's greatest website or social media presence because they are seeing an enormous amount of patients. It's had 6 times the growth that they projected for the first 2 years. It's wildly incredible. But if you get a chance to go out there, please do. It's a beautiful, beautiful practice facility, an incredible staff team. We've been out there for 18 months helping them condense that massive process of having all of these tests done. But the thing that they do so beautifully is not only have a conversation with the parents where they're describing, oh my gosh, here's this chaotic thing, and an appointment with the child to say, oh my gosh, here's all of this stuff, but they're weaving it together so that everybody's supported. And one of the things that they do really well is they actually have support for the couple, the parents, and the child at the same time. So the child will enter a path for, launching into therapy, launching into reconstruction, whatever needs to happen to amp up their superpowers. And then the parents at the same time, if they are facing any nutritional issues, if it points to other genetic markers, if it points to marital issues that maybe they need to start addressing more head on, that support is also in the building, which is just really powerful. And so when you're looking at, CBTI and you're looking at some of these other things, that's where that expansive came out of. I'm a patient with asthma. I had to stop and come to this room and sit for 10 minutes. Why? Because New York City allows people to blow smoke in my face in the 3 blocks I had to walk over from Penn Station. We'll work on that. But these are just realities that I face, and you know better than anybody that in the CBTI world, there's a ton of complications from light fixtures to smells and scented chemicals and things like that that can also cause conflict. So think community-wide when you're focusing in on certain patient populations.
Yeah, I think the only thing that I would add to that is not specific to the concussion community, but we have a youth advisory council where we have teenagers or ages 10 through 18. And really most of the work that we do, not only in our family advisory council, but we also bring it to our youth as well. And it's amazing how innovative and creative they are, and so much more than our adults. And in fact, for our falls committee, they had come in and were asking, the families questions, and sure, we definitely gave wonderful answers and really helped them think about it. But the youth really completely turned it completely over, and they talked about how when they're walking with the IV pole, they talked about their gowns that are too long, where no one had thought about that previously. So I think just really using and building up the community of the actual advisors and making sure they're at the right point in their lives to help, but by looking and hearing their perspectives is really a positive change element.
Great, thank you. We are at time, actually, but Beth, Whitney, and Kathy are going to be here if you all need to ask questions afterwards. So I just want to thank them, and thank you all for coming.